Ding, ding, class is in session. Ding, ding, class is in session. Come on in, get your pencil, your pen, your pad, or your stylet. They call me Miss Rose, and if this is your first time here, thank you for joining us as we break down this content that you will be reviewing in your class as you prepare for the NCLEX. Today, we will be breaking down the medications used to treat anxiety disorders. But first, we got to talk a little bit about anxiety. What is anxiety? A vague, uneasy, emotional feeling experienced by a person in response to a perceived threat or danger. Okay, notice I said perceived threat or danger. So it may not be actual, it may not be happening, but they think it's happening. So it's real for them. We also have a term that I want you to be familiar with called free floating anxiety. This one occurs when a person is unable to connect the anxiety to a stimulus. Okay, so they don't know what they can't pinpoint what it is that's making them feel so anxious, but nevertheless, they still have these feelings of anxiety. Unconscious behaviors that are aimed at relieving the anxiety are known as automatic relief behaviors. And we'll talk a little bit more about this later, but I'll just say we all use automatic relief behaviors, whether it be tapping, bouncing your leg, you know how you can bounce your knee, or tap your foot, or it's just automatic. It's just something that you do automatic. I know sometimes before get into my lecture, I might start swinging in my chair like this. So that is, it's just automatic um, behavior that relieves some of the anxiety. Okay, so all of us experience anxiety at some level at some point in our lives. Some can handle it, others cannot. And if the stressor is not unrelieved, the person can develop a stress disorder. Okay, so let's talk about anxiety can be constant or intermittent and can range from mild to severe to incapacitating. Okay, meaning they can't even move. They can't. It's too much. They can't move. Can't make a decision. You know, it's just they're stuck. But just remember that anxiety disorders are abnormal or irrational reactions to stressful situations that hinder normal daily functioning. All right, let's get to it. Generalized anxiety disorder is excessive worry about a particular circumstance for more than 6 months. And it's the precursor to developing other disorders. So think of this disorder as the mother of, of anxiety who is cranking out babies, right? They have trouble controlling the anxiety, leading to considerable discomfort, lack of concentration, impaired ability to function that cannot be attributed to the substance abuse, so it's not drugs, or any other medical condition. They also experience at least three other symptoms that include restlessness, irritability, muscle tension, difficulty falling or staying asleep, and fatigue. Other somatic complaints may also be reported, like chest pain. You may complain of chest pain, hyperventilating, a headache, tremors, increased urinary frequency, or gastrointestinal disturbances, you know, like a queasy, bubbly stomach. The existence of continued tension and feeling on edge leads to a reduced quality of life and overall dissatisfaction with themselves and with others. The onset is usually in childhood or early adolescence and often associated with stressful life situations. But they don't seek treatment until they're in their like 30s, if they seek treatment at all. So if you ask them, so how long have you been feeling this anxiety? You know, how long you felt that? They'll tell you they've been feeling like this for most of their lives. So they kind of see it as normal. Now let's look at panic disorders. Panic disorders are not a severe form of generalized anxiety disorder. Instead, they consist of unprovoked anxiety attacks characterized by intense fear. Panic disorders is characterized by recurrent, unexpected panic attacks. The frequency and the severity of these attacks um, can vary. Some people may be able to put up with brief exposure to the situation that's causing the panic, but then there are others that may not be able to handle any exposure, right? They're not able to expose themselves to the situation at all. And when this occurs, the consequences of the disorder are much greater and the functional capacity of the person decreases significantly. Sometimes phobias can trigger a panic attack, and that's the next on the list. Phobias, an irrational fear of a specific object, activity, or situation. Got a couple of phobias I want to jot down here. We have social phobias. Let me get my pen. I like writing with this. Is this my pen? It doesn't look like my pen. No, here's my pen. Okay. All right. We have social phobias, which we call agro, AGRO. I like writing on the board, but I can't. Phobia, Phobia. Whew. This is, excuse me, this is fears of situations involving possible scrutiny. For instance, public speaking, performing in public, starting your YouTube channel for fear of being judged. This is agoraphobia. They may exhibit symptoms like hyperventilation. They may start sweating, blushing, having palpitations, confusion, trembling of the hands and the voice. Sounds almost like a panic attack, right? They also may have some GI complaints, GI symptoms like a nervous stomach, diarrhea, vomiting, especially, during their public speaking. Muscle tension. They may have cold, clammy hands. Has anybody experienced this? You know what I'm talking about? Okay, especially when you have to get up in front of people. There are specific phobias, right? One is this agoraphobia about social, but there's fears of an object or a situation that can provoke immediate, intense, anxious response, like blood. People see blood. That's hematophobia. Um, Hematophobia. Then you have spiders. People are afraid of spiders. They freak out when they see a spider. That's what arachnophobia. Arachnophobia. Uh-huh. Yeah, I know I can't write. And then you have people that are afraid of heights. That's acrophobia, not agro, but acro with the C. Phobias can interfere with work, they can interfere with school, socializing with others. And then you have adolescents and adults. They are usually aware that their responses to the trigger is extreme and unrealistic. But guess what? It's there and there's nothing they can do about it. Okay. I mean, we've got some treat. We're not going to get into that right now because this lesson is about the medications, but there are different types of modes of treatment for these people who suffer from these phobias. And one is exposure, right? It kind of expose you a little bit, but we'll talk about that in a different lesson. Obsessive compulsive disorder. That is your OCD. It is the most disabling of the anxiety disorders, but it responds well to treatment. Okay? Obsessions, when we talk about obsessive compulsive, obsessions are unwanted thoughts that are time consuming and senseless. Unwanted, they don't want to be thinking these thoughts. They're taking up all of the time and they make no sense. And a compulsion is repeated purposeful behavior performed to decrease the anxiety associated with the obsessive thoughts. So it's this back and forth thing going on and often becomes ritualistic. For diagnosis, the obsessions and the compulsions have to be severe enough to cause significant decline in the client's level of functioning, with the actions consuming at least 1 hour of the person's day. So they're taking an hour out of their day to do these rituals or these compulsives. Hoarding, hoarding disorder is a form of OCD. People experience persistent difficulty disposing of possessions regardless of their actual value. Clients may recognize the obsessive thoughts as unusual and self-generated, right? They know they're creating these things, but they lack the ability to control them. And this lack of control leads them to the extreme anxiety. So, in an attempt to deal with the anxiety, the person performs these repetitive acts that serve no purpose. Remember, they're purposeless, serve no purpose, but it relieves the anxiety. So, in the example of the hoarder, I don't know if you guys ever watched the show about the hoarders, but in the when it's when they deal with the people who have the hoarding tendencies, the hoarding disorder, you'll notice that they touch the stuff. They keep touching the stuff, right? Especially when it's time to throw it away, right? Everybody's come to the house, they done put stuff in piles. Okay, these are all of your knickknacks, these are all your shirts are the same color and the same style. How many do you want to keep? Which ones do you want to give away? And they have to touch everything. They just touch it like that's the compulsion, right? To touch. The obsessive is the thought. So the person, another example is the person who feels contaminated with sexual thoughts may wash their hair repeatedly until the scalp is bleeding. And the person with violent thoughts of harming their family may check locks and gas knobs every few minutes, or they may clean counters repeatedly. Like, didn't you just wipe down that counter? And they're coming right back, wiping down the counter. In the person with OCD, the symptoms severely interfere with social and occupational functioning. Okay. The ability to finish a task is impaired by lack of concentration, invasion of the obsessive thoughts, and the need to perform the actions. So that one is the most debilitating. Okay, let's go on. I have a question for you. What characteristic defines generalized anxiety disorder? Is it A, it is more prevalent among older adults? Is it B, it frequently results in additional psychiatric disorders? C, it starts suddenly? Or D, diagnosis occurs after experiencing 2 months of anxiety symptoms? Which one do you think it is? I'm going to give you like 2 seconds to drink my juice. Okay, what you pick? Let's see. Did you pick B? Very good. Remember, generalized anxiety disorder is characterized by excessive and unrealistic worry about multiple life circumstances for a duration of 6 months or longer. Individuals with this disorder are usually in their 20s and 30s and often develop other psychiatric conditions like the panic disorder, obsessive compulsive disorder, social anxiety disorder, and major depression at some point in their lives. Remember, this one is the mother that's cranking out those babies. Okay, so we just went over that. Okay, here we go. Um, Of all the anxiety disorders, now you should get this one right. Of all the anxiety disorders, which one is considered to be the most disabling to the patient? Is it the generalized anxiety disorder, the panic disorder, phobia, or obsessive compulsive disorder, the OCD? Which one do you think it is? Let's see. Which one did you pick? Are you ready? This one shouldn't take very long. We just talked about it. What you pick? Did you pick obsessive compulsive disorder? Very good. OCD is the most disabling anxiety disorder because it can interfere with normal occupational responsibilities, social activities, and relationships. Very good. Oh, got another question for you. Which of the following chart entries by the nurse would demonstrate progress in the client who experiences agoraphobia? Agoraphobia. Now you have to remember what agoraphobia is. We talked about it like 4 slides ago. And you want to know which chart entry, what did she write in the chart that would let somebody know that this patient is progressing? Did she write attends group I just say she, it could be a he. Did they write attends group therapy sessions 4 out of 5 times a week? Did the nurse write conversing with 2 other clients during mealtime? Or did the nurse write participated in outing to park this afternoon? Or did they enter has showered and shampooed hair once daily? How do you know that this person is making progress? The person with agoraphobia is making progress. What did you read in that chart? Okay, what do you got? Ah, participated in outing to park this afternoon. Okay, why that one? Why you think that's the answer? Well, I'm going to tell you. Agoraphobia is the phobia of going out and being in public, right? Remember, speaking in public, performing in public. So for them to have gone outside, that means that they are making progress. Okay. What about this one? Initially, which nursing intervention would receive the highest priority for the client with OCD? Is it one, confront the client about the ridiculous nature of the behavior? Two, we don't even like the way that one sound, does it? Do we? We were not going to pick that one. Okay, number two, so we just scratch that one off the list. Number two, isolate the client to reduce proximity to others. Okay. Number three, set limits for client to conform to unit schedule. Or four, allow extra time for the client to perform rituals. Which one do you think is the correct answer? One, two, three, or four? Let's see. What do you got? Okay. You ready? Okay. It is allow extra time. Allow extra time for the client to perform ritual. It looks like some of you wanted to set limits, which would be okay if it weren't OCD. If you prevent a person with OCD from performing their rituals, guess what's going to happen? You're going to increase their anxiety levels. Not good. Remember, we want to lessen their anxiety. So we'll give them time to perform we'll give them extra time to perform their rituals. Very good. Okay, now when we're looking at the assessment of the mental status, remember, Nursing is a systematic, it's an orderly um, function. So we start with what? The assessment. So we want to look at the history or behavior. Are there triggers increasing anxiety that include recent loss of a job, breakup in a relationship, things like that? The history also includes details of all medications that they're taking because we know that some medication can cause depression, suicidal thoughts, um, our basic mental status. Two areas we're looking at. Is the patient at risk for harming him or herself? And is this person able to participate in ADLs, their activities of daily living? We want to assess the mood and the affect. What is the patient's mood? Is it tearful, excited, angry, hostile, apathetic? Are they sad? And is it congruent? Is their facial expression congruent with what they're saying? If they're saying they're happy, they should look happy. Clarity of thought. We want to evaluate the patient's coherence and organization of thoughts as well as their ability to make judgments and decisions. Psychomotor functions. Is the patient able to fulfill responsibilities at work and socially? Obsessions or compulsions, we want to assess the patient's persistent thoughts, repetitive behaviors, and how they impair work and social functioning. It's all about can they function. Sleep pattern. We need to determine the amount and the quality of sleep. Are they falling asleep but not staying asleep? Are they having trouble falling asleep? Dietary history. We need to determine the appetite and need to gain or lose weight. Treatment is going to focus on reducing the client's anxiety level and teaching them that they have the ability to control their thinking and ultimately their actions. Outcome is best if both medications and counseling are used together. Now let's look at some drug therapy and drug dependence. First on the docket is benzodiazepines. Okay, specific benzodiazepines, the AMs and PAMs, like oxazepam, lorazepam, diazepam, uh, clonazepam. Uh, that would be your let's see, what I said, Cerex, Ativan, Valium. You also have clonopine. That was your clonazepam, and then you have alprazolam, which is Xanax. Okay, so those are those drugs that end in am or pam, AMS, or not AMS, but AM, and PAM, PAM. You have a couple that don't end in either am or pam, and that's your chlorazepate, your chlordiazepoxide, which is your Librium. Okay. Um, Psychotherapy is also a treatment for generalized anxiety disorder, along with those benzodiazepines. Barbiturates not recommended because they are highly addictive and they come with a bunch of adverse effects and they have a low therapeutic indices, meaning that um how can I say this? The therapeutic indicators are very low. Okay. Benzodiazepines seem to work well um, through the stimulation of the GABA, gamma aminobutyric acid, which is an inhibitory neurotransmitter that provides sleep and reduces tremor and muscle tension. So that's good, right? You're gonna hit a whole bunch of stuff. Buspar, Buspirone is comparable with the benzodiazepines in reducing symptoms of anxiety, and it has fewer sedative and withdrawal adverse effects. It also has fewer cognitive and psychomotor adverse effects, which which makes it a more favorable drug for our older adult patients. Now, the SSRIs, I refer to those as the TV drugs because they all have commercials. Okay, you may have seen them. I know you guys don't watch TV. Y'all do other stuff, but for my generation, we watch TV, and so there's Celexa, there's Lexapro, there's Prozac, Paxil, Zoloft, Luvox, all are preferred over other antidepressants because their adverse effects are less and they do not have the risk of cardiac dysrhythmias associated with the tricyclic antidepressants. Okay, and all of these drugs, Lexapro, Paxil, they all on TV. All of them have their own commercials. Some of them are kind of good too. All right. Um, So these drugs work by blocking the reuptake of serotonin, which makes more serotonin available in the brain. And we know serotonin is a happy neurotransmitter. It's a mood, one of those mood transmitters, makes us feel good. These drugs can cause anxiety, though. They can cause anxiety, they can cause agitation, dizziness, migraines, depression, the very thing we're trying to fight. Um, Fatigue, dry mouth, nausea, diarrhea, uh, also increased weight gain. I'm sorry, increased or decreased weight gain. Okay. So let's unpack this because I'm sure if you understood what I said, I'm not sure if you understood what I said. And sometimes this is the problem when students are studying. They read this stuff but don't understand what they're doing or what's being said. So let's unpack some of this. SSRIs, these drugs don't have a lot of side effects. They don't cause cardiac dysrhythmias and are the preferred drug over an antidepressant like your tricyclics. These drugs end in pram and ine. Okay, that's the drug. They end in. They are right there. Pram, Celexa, uh, Lexapro, or you can say AM. You can also say they end in AM, but they're not an AM and PAM. They're a PRAM, PRAM. Okay, and then you have Prozac, which is fluoxetine, and then you have Paxil, which is a pyroxetine. So they kind of end in some ines too, right? But this is kind of how you can group these drugs if you need to group them so that they make sense. Um, Buspar. Buspar works as well as the benzodiazepines, but it doesn't make your patient drowsy. And if they stop taking it, they won't have the cognitive and psychomotor effects like from when they get off the drug. So if they stop taking it, they won't get those withdrawal effects like they do with some of the other drugs. So these drugs can cause drowsiness, dizziness, ataxia, that's something with the gait, right? Remember? Lethargy, hypotension, blurred vision, nausea, vomiting, anorexia, a host of stuff. Sleep disturbance, tolerance, they can build up a tolerance, physical and psychological dependence. So, but most are used to treat anxiety from alcohol withdrawal, but not alprazolam. Alprazolam is not used for alcohol withdrawal. You can't use that one. Okay. Now, routine lab has to be monitored, and the lab work includes RBCs, WBCs, liver function tests, AST, ALT, and GGT. Okay. Also, alkaline phosphatase. So, with these drugs, you want to be monitoring liver enzymes, liver function tests, RBCs, and WBCs. All right. Now we have buspirone or Buspar. This one is another antidepressant that works as well as benzodiazepines, but it doesn't make your patient drowsy, and they won't have those cognitive and psychomotor effects if they stop taking it, and they won't get what? Those withdrawal effects. But they can get toxic. So this drug works by balancing that serotonin and dopamine, and we know that both of these neurotransmitters help with mood. So there can be some unusual excitement, right? This medication can cause drowsiness, dizziness, excitement, fatigue, headache, insomnia, some nervousness, some weakness, blurred vision, nasal congestion, palpitations, tachycardia, nausea, rashes, myalgia, and incoordination. Okay, and none of that is, let me see, is any of that listed on our toxicity list? Did I say nausea and vomiting? Nope, I said nervous. Yeah, I did say nausea. Okay, we got a little nausea, but no vomiting. Okay, so gotta watch out for these signs of toxicity, which is, even though there might be some dizziness, this is severe dizziness, lightheadedness, severe drowsiness, loss of consciousness, nausea and vomiting, and constricted pupils. So, I mean, it is a safe drug. It's a good drug for the patient who is suffering from these generalized anxiety. However, it doesn't come without caution. So you have to be able to watch out for these signs of toxicity. So our treatment for panic disorders, let's look at panic disorders. They aren't as cut and dry. Okay. There's behavior therapy, there's medications. Um, there are major limitations, which include lack of anti-panic activity. This means that the medication does not effectively reduce or prevent panic attacks in some patients. There's reduced anxiolytic or anti-anxiety effects in patients who have recently stopped taking benzodiazepines like Xanax, Ativan, or Clonopine. And these patients may experience less anxiety relief from the new medication, likely due to their brain adapting to the sudden absence of the benzodiazepines, which is fast acting. It has a strong calming effect compared to other medications. So, what do you anticipate the physician to order for those patients transitioning off benzodiazepines? What do you think his order will be? Anybody? Okay. Well, his order may be slow tapering, right? So the patient will um will not abruptly stop taking these meds. Okay? SSRIs, they are generally the drug of choice for long-term treatment, and tricyclic antidepressants like norpinephrine, anafranil, and Remeron, those are the tricyclic antidepressants. We'll look at those in a bit too. Oh, we're looking at them now. Okay, so think of a little one riding the tricycle or big wheel, right? They're just tearing down the street with the wind in their hair. Tricyclic antidepressants give them that feeling, okay? And that listed on the slide here. There's norpinephrine, anafranil, Remeron. We just named those. Um, but we need to teach them to watch for signs of sedation, orthostatic hypotension, dry mouth, urinary retention. Does that sound like anything to you? Does that sound familiar to you? Well, to me, it sounds like an anticholinergic. So these drugs have anticholinergic effects. They will have an anticholinergic effect. Also, watch for tachycardia, decreased sexual ability, or decreased libido. They need to be taught that. They need to be educated on that if they're going to be taking these medications. They need to know this. But tricyclists make them feel really good. All right, treatment for obsessive compulsive disorders. Here again are our TV drugs, our SSRIs. These drugs are used often for mild anxiety. They're not addictive. So serious adverse effects do include slurred speech, dizziness. Remember, these have a low addictive rate, but they may cause anxiety, agitation, dizziness, migraine, depression, fatigue, dry mouth, nausea, diarrhea, increased or decreased weight. Remember that. So, um, anti-anxiety medications are contraindicated in clients with hypersensitivity, narrow angle glaucoma, pre-existing central nervous system depression or psychosis, and in clients who are pregnant and lactating, younger than 12 years, or in shock or in a coma. They can't take this drug, okay? They shouldn't be taken in combination with CNS depressants either. Um, let's see what else did I want to say. Oh, we need to use caution in older adults. Use caution in older adults. Those with hepatic or renal, hepatic meaning what? Liver, renal meaning what? Kidney dysfunction. We need to be checking labs. A history of drug dependence or abuse and depression. They shouldn't be taking these meds. Physical dependence is indicated by withdrawal symptoms if discontinued abruptly. So if they stop taking this drug abruptly, just stop, and they get withdrawal symptoms, we know that they're physically dependent on the drug, okay? That's how we know. Severe withdrawal symptoms, oh my God, what was I getting ready to say? Severe withdrawal symptoms are most likely in clients who have taken higher doses for a period of more than 4 months. 4 months that's the number. Common symptoms include increased anxiety, psychomotor agitation, insomnia, irritability, headache, tremors, and palpitations. In severe cases, psychotic manifestations and seizures may occur. So, the expected therapeutic outcome for benzos and SSRI. So, when you get questions that ask you to evaluate the effectiveness of the medication, these are some things you should be choosing in your answers. Okay. Decreased in level of anxiety to a manageable level. So say they was a 10, we got them down to an 8. That's a decrease. Coping is improved. They're not tearing up furniture and things like that. Physical signs of anxiety, such as a look of anxiety, is gone, right? They look like they're a little more relaxed, calm. Tremor and or pacing has lessened, right? So they're not walking the floor like they used, it's lessened, it's better. That's how we know. So let's see what you remembered. Nursing priorities. Prevent injury from medication, side effects, seizures, increased anxiety, effects of the medication, toxicity, or overdose. You need to maintain normal activity levels and a balanced diet. We don't want them losing weight, and we also don't want them overeating as well. Sedation, confusion, or lethargy can cause reduced anxiety and weight gain. We want to prevent confusion and disorientation related to the effects of the medication on the CNS. Um, For our interventions, our actions, we want to assess the client mood and orientation daily. Monitor lying and standing blood pressures daily. Why are we doing that? Because we said some of these drugs cause orthostatic hypotension, didn't we? Yes, we did. Assess for paradoxical excitement. Paradoxical excitement means that the patient is experiencing emotional lability, agitation, excessive movement, and confusion, and it may be accompanied by increased autonomic activity like tachycardia, hypertension, and tachypnea. All right. Um, and if this is the case, we need to notify the healthcare provider if we notice these things. Offer ice chips, hard candy, frequent sips of water, sugarless gum to relieve the dry mouth. We want to give this medication with food or milk to prevent what? The nausea and vomiting, the GI complaints. Report any indications of blood dyscrasias. Blood dyscrasias is one of my favorite words. I love that word when I learned what it was when I was in nursing school. It became my favorite word. But any signs of dyscrasia would be a sore throat, fever, malaise, bruising, or unusual bleeding. Um, Dyscrasia just means that all of the labs are off. They're just all abnormal, every last one of them. Observe for side effects of anti-anxiety drug therapy. We want to encourage participation in social interaction and exercise activities. We want to give positive reinforcement for the client's efforts to participate. We want to teach stress management techniques, progressive relaxation, music therapy, deep breathing. We want to assist the client with compulsive behaviors, but let me go back. We want to teach these relaxation techniques, stress management techniques, but we don't want to teach them when the anxiety level is at 10. We got to wait till we get them down and then teach them because you can't, they won't be able to learn anything when their anxiety is that high. Okay. Now we want to assist this client with the compulsive behaviors to find ways to set limits on their rituals. How can they do that? Well, maybe they can do it they can do it like before therapy, but not during therapy. You know, we want to try to set some limits on the rituals. Acknowledge the behaviors, but do not focus on them. It is important to express an empathetic response rather than criticize the behavior, right? We want to empathize with them. For example, in response to the client who shampooed her hair 4 times in 2 hours, the nurse might say, I'm sure your scalp is getting sore from washing your hair so much, rather than you only need to wash your hair once a day. You know that, right? That's not helpful, people. Not helpful. So we want to empathize when they feel like they got to do it. So if they have to do it, then we just, try to express more empathy. We need more of that in the world anyway. We want to observe for those automatic relief behaviors. Remember I told you we was going to talk about that? Okay, we're at it now. These are not necessarily bad in and of itself, but some of those behaviors could be rocking. Have you ever seen people rock? They rock back and forth. I mean, some are exaggerated rocking, but some people rock, they might bounce their knee, they might do their knuckles, crack their knuckles. Again, those things many of us do on a regular. They are not bad in and of itself, but they are automatic stress relievers. And of course, we want to encourage them to express their thoughts and feelings. Avoid giving advice, right? You want to provide education regarding their meds and the side effects, and you want to provide resources, but you don't want to be giving your advice or you don't want to be judging. Okay, so if you ever get a test question and you see where it says what is the nurse's best response? And one of the responses is, you should tell the doctor, or you should no, you should divorce him. And no, no, that's the wrong answer. Don't pick that. Okay. All right. Very good. Now, I'm including this slide because students often confuse goals with interventions. Goals almost always start with client will. Client will experience no physical injury. Client will tolerate usual activity without excessive sedation. That is a expected outcome. That is a goal. If you find yourself writing monitor, no, that's an intervention. That's something you're going to do. Monitor vital signs or monitor labs. That's something you're going to do. Goals always, almost always start with client will. If you don't find yourself writing client will, you're not writing a goal or a outcome. So just erase that and start over. Now, remember, the most common side effects of anti-anxiety medication is drowsiness, fatigue, confusion, and loss of coordination. Remember, ataxia, loss of coordination. So we should be teaching them to what? Rise slowly from a reclining position because of what? Orthostatic hypotension, right? Remember that? Loss of coordination. Okay, very good. Now, they also should avoid driving. They should avoid driving or operating dangerous machinery while they're taking this drug, or at least until the body gets used to it. Clients taking Busbar may experience a lag time of 10 days to 2 weeks between the onset of therapy and the reduction of their anxiety symptoms. And they should be told this and to continue taking the medication during that time. No, you're not going to see any improvement, but you still have to continue taking this drug and you will see improvement within 10 days, right? Okay, remember dyscrasias? They should be instructed to report any symptoms of what? Fever, sore throat, malaise, easy bruising, bleeding, or increased motor restlessness. They need to report that to the provider. Okay, that's not an outcome. That's that's not a client will. I mean, well, if you're teaching that, if that's your goal, client will report signs of fever, sore throat, because those are signs of what? Dyscrasia, blood dyscrasias. Okay, we have a question here. Which is the most common drug class used to treat anxiety disorders? Okay, what do you got here? What did you pick? Is it A? Is it B? Is it C? Or is it D? Let's see what you picked. It is C. Benzodiazepines. These are most commonly used to treat anxiety disorders because they are more consistently effective, less likely to interact with other drugs, less likely to cause overdose, and have less potential for abuse than barbiturates and other anti-anxiety agents. Just a FYI, they account for perhaps 75% of the 100 million prescriptions written annually for anxiety. Yes, that's a lot. Okay, what do we have here? Another question. What must be used with caution while taking anti-anxiety agents? Look, this should be a no-brainer. What's the answer? The answer is what? B, alcohol. Alcohol has an addictive effect when taken with many anti-anxiety medications and may cause increased anxiety or drowsiness. All right. There it is right there. In case you didn't believe me. Okay. Now, a client with generalized anxiety disorder approaches the nurse and states he feels dizzy. Which of the following would be the best response for the nurse to make? Don't worry, it is just one of those symptoms you can expect. Okay, does anybody remember seeing dizziness on the list? All right, okay, another one. Stay right here. I will be back with some medication to help you. Mhm. Okay, all right, you got another one. I'll help you to your room so you can lie down and rest until you feel better. Sounds good? Okay, we got one more. Can you tell me what happened about the time you started feeling this way? Haha. So what's the answer? Da-da-da, doo-doo-doo. The answer is, can you tell me what happened about the time you started feeling this way? Why is that the best choice? It's the best. Well, the other choice was just brush them off. Well, it's just something that happens. And one of the other choices was just stay right here. I'll be back. Are we going to leave him there? Are we going to leave our patient there? They just told you they were dizzy. No, that's not safe. And the other one was something about taking him to his room and lying him down till he felt better. No, no, no. We need to do an assessment. Remember, the nursing process, we need to do an assessment. Tell me what happened about the time you started feeling this way. Very good. Um, Question. A client has just been diagnosed with panic disorder. Which of the following symptoms should the nurse expect to observe? This patient is in panic mode. Will they have hypotension, feelings of suffocation, constipation, and logical thought processes? Well, I think we can eliminate one already. I see one we can eliminate already. Okay, what do we have here? What'd you pick? Ooh, feelings of suffocation. Did anybody pick constipation? I think you remembered that there may be some GI symptoms, but if you recall, the client may experience a nervous stomach. So that would be what? Diarrhea, not constipation. But good. Okay. Which of the following is the most appropriate initial outcome for the nurse to set for the client experiencing a panic level of anxiety? Another panic. Oh, and this is what? An outcome. You can tell because it says what? Will. Patient will. Patient will develop a trusting relationship with the nurse. Patient will demonstrate insight into cause of anxiety. Patient will identify alternate methods of coping, or patient will reduce anxiety at least one level. So which of the following is the most appropriate initial outcome? What do we want to do first? What do we expect first for the nurse to set for the client experiencing a panic level of anxiety? Okay, what you pick? Let's see. Did you pick will reduce anxiety at least one level? Well, you should have, because if we can get them down at least one level, we may not get them to totally relax. That's not realistic. And remember, goals must be what? Smart. Smart goals. So if we can get them down one level, if we can get them from 10 to 9, we showing progress. All right, so let's recap. Let's sum this up. The drugs, oxypam or Cerex, lorazepam, Ativan, chlorodi chlorodiazepam, shoot, chlordiazepoxide or Librium, diazepam, Valium, or clorazepate transine. These are our benzodiazepines. They work as CNS depressants. They reduce anxiety by stimulating the neurotransmitter GABA. They're used to treat anxiety associated with alcohol withdrawal and medical illnesses. All except for the alprazolam are used to treat anxiety from alcohol withdrawal. Okay, these are the drugs of choice due to their short half-life and their high therapeutic index. Remember that other drug had a low therapeutic index? I think those were the barbiturates. These have a high therapeutic index. So they work by binding to specific receptor sites, and these agents appear to potentiate the effects of GABA and facilitate inhibitory GABA neurotransmission and other inhibitory transmitters. All right. So common adverse effects is going to be what? Your drowsiness, feeling like you got a hangover, sedation, and lethargy. Serious side effects, excessive use or abuse, blood dyscrasias, and hepatotoxicity. So we got to do what? Monitor those labs, RBC, WBC, liver function tests, AST, ALT, GGT, and alkaline phosphate. Okay. Habitual benzodiazepine use may result in physical dependence. Rapidly discontinuing benzodiazepines after long-term use may result in withdrawal. And we stated the long-term use. I got a question in here too, I think somewhere. I'm gonna see if you remember. Okay. Um, Withdrawal symptoms for the benzodiazepines: restlessness, worsening of anxiety or insomnia, tremors, tremors, muscle tension, increased heart rate, and auditory hypersensitivity. So you're talking too loud. The music's too loud. Turn the TV down. Auditory hypersensitivity. We didn't talk about this drug too much, but there's a anti-anxiety agent which is actually categorized as miscellaneous. It acts as an antihistamine, and it's called Vistaril or Atarax. Those are the two drugs. Um, Mild tranquilizer for anxiety, tension, agitation, sedation. We give it for relaxation before surgery. That way we don't have to use as much anesthesia. And it's also antihistamine. Antihistamine controls itching and allergic reactions. Um, Well-known antihistamine is what? Benadryl, right? Okay. So it's used often for mild anxiety, and it's not addictive. Visceral is not addictive, but the serious adverse effects for this one is slurred speech and dizziness. But common adverse effects, because it is an antihistamine, it's going to dry everything up. It's going to dry everything up like a anticholinergic. So it's going to be blurred vision, constipation, dryness of the mucosa of the mouth, throat, and nose, and then again, it's going to cause the sedation. Another drug class, we talked about Buspar, the azaspirones. Um, it is a partial serotonin and dopamine agonist. So, what does that mean? It means that this drug is going to bind to receptor sites and activate something. In this case, serotonin and dopamine, the feel good neurotransmitters, the happy mood neurotransmitters. Um, Common adverse effects, of course, sedation and lethargy. It is short-term relief of symptoms of anxiety, so this shouldn't be used like long-term. This is short-term release. Serious adverse effects, again, slurred speech and dizziness. This one has no antipsychotic activity and should not be used in place of appropriate psychiatric treatment. Okay? All right. Hey, that's it. We got through another class. Thank you for watching the channel. If you like the content, please hit the like button. And to be sure you don't miss anything new, go ahead and subscribe. You can share it with your classmates. You can share it with your study partner. You guys can go over it again. I'm here for you. There are no products. There's no merch. Just me breaking it down. Class dismissed.